those of you who are familiar with WISH will know that for some time it has facilitated work not just on showcasing innovations, but also identifying what stands in the way of healthcare, adopting and embracing the new and the good. Technology, ways of working, culture, ways to influence patients and indeed the public. The latest Global Diffusion of Healthcare Innovations study focuses on biases in decision-making and identifies practical interventions or nudges that encourage the take-up of worthy new ideas. This is a topic of so much importance, not just to health, but to society as a whole. And I'd like to invite the members of the panel who are here to discuss this to come onto the stage now. Thank you. Here with us with your various perspectives, which we will bring out in a moment. Dr. Arsen Torossian, in the middle there is the Minister of Health from the Republic of Armenia. Maureen Bisognano at the end is President Emerita and Senior Fellow at the Institute for Healthcare Improvement, based in the US. Dr. Fadi Maki is head of the Qatar Behavioral Insights Unit, Qatar 22 Supreme Committee. And Dr. Greg Parston has been working on this subject for a long time because Greg leads on the global diffusion of healthcare innovation at Imperial College London. And before the discussion, Greg, I'd like you to set out what is in the latest study, what it's identified and its recommendations.
Thank you very much, Michelle. The work on the global diffusion of healthcare innovation started at Imperial College in 2013 at the Institute for Global Health Innovation, which is led by Professor Darzi. We were aware and are aware that, of course, there's a great deal of innovation in healthcare, but it takes too long for new techniques, new products, new policies to go from what we've called bench to bedside. And so we decided to try to focus our research program on diffusion, on taking a look at the processes for adoption of innovation and the spread of that innovation across systems to transform systems and to achieve better outcomes for patients and communities. In 2013, we developed a framework which comprised a number of systems, factors, and a number of frontline behaviors that we thought would be the basis of study over a number of years. And we approached the Qatar Foundation, who since then has very generously supported a program of work which has resulted in one of the principal primary research studies of WISH. These past 5 years have been a bit of a helicopter ride, Michelle, and for those of you who have been here since the beginning, I hope that you will appreciate the journey. We began in 2013 at a very high level, looking at a number of countries to measure quantitatively the importance and prevalence of those systems enablers and frontline behaviors, and found that some were important, others were less important. In 2015, we came down in the helicopter to take a look in great detail at 8 case studies of successful rapid diffusion. Diffusion which resulted in transformation of systems, in some cases in months, in some cases in 7 or 8 years. And those countries range from Nepal to Argentina, from Singapore to the UK. In 2016, we repeated some of that work, taking a specific look at frugal innovation. But this year, in 2018, we brought that helicopter right down, and we're looking at organizations and within organizations at the people who actually decide whether or not they're going to pick up the new practice, the new policy, the new product. And in doing so, to examine the biases that may affect their decisions about adoption and about innovation. Working with BIT, the Behavioral Insights Team, which is a research and consultancy group in London, some of you may have read about them just in this past week's Guardian. We structured some research to take a look at behavioral biases and what could be done to try to overcome some of those biases in 5 countries using 2 online experiments and recruited over 1,800 respondents to participate in two tests. Beginning with literature reviews of cognitive behavior, we identified 6 biases that we wanted to look at. Outcome, source of information, status quo, that is the products and practices already used, sunk costs, the weight of averting loss over gaining benefit, and the relative risk or superiority of a particular innovation. And we structured 2 experiments. One was to test the effects of cognitive bias to see whether indeed biases were there. And secondly, to see if we could provide some way, some nudge of reducing the effects of those biases. For each of the 6, we created a vignette, a story, which asked the respondent to make a choice. And we had a control text, which asked the respondents to decide whether a new product should be used or a new procedure should be used or whether they would retain the old. And then a second text given to the second half of the sample in which we treated the text in a way to induce a bias. I'm not going to go through all of those 6, but I brought a couple with me just to give you an idea of what we try to do. So in one case, this is a source bias in which we are asking people to make a choice between 2 types of surgical drills. One was the standard Braun surgical drill, but the second was something which was called the Ladox drill, which was a drill very much like that used in industry. In the control text, that drill was developed at Harvard University. In the treatment text, that drill was developed at Uganda's Makerere University. And we asked people to make a choice about whether they would use the new drill or the old drill based on the source of the development. In the second case, which is about outcomes, the participants were asked to choose between 2 surgical techniques for cardiac surgery. One was still heart surgery, the second was beating heart surgery. The participant was told that he or she had used the beating heart surgery previously on their patient named Sarah. In the control text, Sarah survived. In the treatment text, Sarah died. What we found in all 6 cases was that bias can have an effect on reducing the uptake of innovation and in slowing down diffusion. In all 6 cases, in all 6 vignettes, the treatment resulted in a lower uptake of the innovation, the treatment text. We found no predictive value in gender, age, or experience in our analysis, but we did find that doctors, in all cases, were less likely to take up the innovations than nurses were. So what we did in the first bit was to confirm that there are biases, there are cognitive biases. Now, these aren't bad things, and I've argued, and many others have as well, that this is actually the flip side of a very strong characteristic in clinical practice, which is doubt. The skepticism, the propensity to inquire, the doubt that people bring to clinical diagnosis. But that can sometimes work its way as a bias in picking up new procedures, new practices, if evidence, if other kinds of information aren't presented in the correct way or in a way which makes people consider their choices more carefully. So in test 2, what we wanted to do was to see whether we could present information, whether we could make a behavioral intervention, or what Michelle has called a nudge, to see whether people could take a different kind of choice or make a different kind of choice. So in test 2, we used the treatment text, that is the text that induced the bias and that resulted in lower uptake, to test all of the participants. But in some cases, we gave them a little bit of additional graphical information, and in other cases, we gave them a little bit of additional text information or behavioral information. And here in the source test is an example of that. In the graphical information, we merely gave people a picture of a histogram that related the cost of the Braun drill to the Ladox drill. In the behavioral intervention, we told people that a respected orthopedic unit in their country recommended it and said that it was better to use, is good to use.
So it was an expansion of the way that the same material was presented.
Well, and remember, it was the treatment text. It was the one that induced the bias.
Okay. Okay. How many more have you got?
I've got a few more.
Okay. Can you do them in 30 seconds? Because then we'll come back to the discussion.
Treatment and the outcome bias, we did the same thing, comparing one surgeon to a number of other surgeons, which showed that the mortality rates declined as surgical numbers increased. What we showed, in fact, was not only that the cognitive biases can affect people's choices around the uptake of innovation, but that there are simple, low-cost techniques and interventions that can reduce this. I won't go through all of the things that we've suggested to help leaders try to meet these biases and try to overcome them. There are a number of recommendations in the report that are about about strengthening reasoning skills, and there are a number of other recommendations that are about providing the physical support to help clinicians and managers make choices that are more inclined to pick up innovations and to begin doing things in new ways.
Okay, and perhaps we can come back to some of those, but the bottom line is we are biased. Perhaps, I think from what you're saying, doctors are more biased than nurses, perhaps. Perhaps. And, but there are ways that that can be combated. I want to get the thoughts of the panel before I turn to all of you. Arsène Torossian, from your perspective as a health minister of your country, do you watch the recommendations and the findings of a report like this and think that there are thoughts in this that can help you when it comes to, delivering more and better healthcare to the citizens of your country?
Sure. Of course, we should consider the findings of the report and make considerations to maximize the likelihood of the success if we try to make some innovations and try to bring new techniques, whether there are clinical techniques to the frontline workers or the decision making on the higher levels. And of course, we should consider this, yes.
What are your biggest challenges in the healthcare system in Armenia?
Oh, but this is not. But this has nothing to do with this report, I guess. Starting from moving from curative care to preventive care as worldwide, I guess. But I think the biggest challenge is our public spending on health. Because we are in the worst 10 countries in the world. We have 1.5% of GDP spending on public spending, I mean. The second challenge is the universal health coverage. I guess we are now moving to this direction to have covered everybody for the basic package. And the challenge is, we know that this is a challenge because the recent report shows that we have 80% out-of-pocket payments, 80. This is again the biggest, one of the biggest in the world. And the second and the third, I guess, is combating the cancer. We don't have a cancer strategy in place, and we are thinking of developing one. We have three main directions, I told.
Maureen, if I can turn to you, I know that you've done a lot of work over the years on finding the ways that health systems in different parts of the world can improve. So how much do you think doing the sorts of things that Greg has outlined, finding the ways that innovations that can really make a difference, they might be cheaper, they might be better, they might be both, can actually help do the job of improvement on a large scale?
Thank you. And it's a fantastic report in so many ways. But I do think that for leaders especially, there are three things that I would share with you that link into the report. The first one is that I think it's our job to build the will for change. Everybody is so busy that to take on a new innovation requires energy and time and commitment and skill. And so the way that Dawn Berwick and I have done this for many years is to recognize that people in the audience have a different point of view on that particular innovation. So I would often start by telling a story of a patient and telling the story of that patient over time so that the healthcare providers get to see the innovation and the impact it has on a person. That touches people's hearts. Then you can talk about the human impact and of this new innovation, and then you can look at the total population that could benefit from it, and then you look at the financial impact. So creating an arc of a story from a patient to the impact can produce energy in people who have very different perspectives. The second one is I think we need to help people learn to see. The nudge, I think, that's probably most effective is getting people out to the field to see the way other people do it. They think all the biases come to play. But I adapted a method from the Harvard Business School when I was over there visiting and asked them how do other industries accelerate the uptake of innovation. They said live case visits, which is a visiting where the poorer performers, so to speak, go to visit someplace. And I can tell you that we've led these around the world, and it's so profound to watch the faces of doctors and nurses as they're standing in the hallway and they're saying, I've totally underestimated my patients, I've totally underestimated staff, I thought I was different and unique, but when you actually see the way a higher performer does it, it inspires people to take that up.
But it's time-consuming and it's a big commitment.
It's a
and
day.
Expensive to send.
It's a day, yes. Yeah. It's a day. And so they're right, it is time. Which brings me to my third point, which is in the report we call it delayering, but I call it exnovation. It's getting rid of all the stuff in people's lives that add no value. And I think unless we're getting really good at exnovating the things that don't, in healthcare, we never do this. We only add. So we need a process that says we're going to methodically go through and stop things that add no value, deprescribing medications that aren't producing an outcome anymore. The undiffusion of a guideline when you diffuse a new one. Exnovation.
Exnovation.
Yeah, it's taking away the stuff that allows people to have the energy and the passion and the time to innovate. And if we don't do that, I think we're just overwhelming people and the spread will be really challenging.
Well, Fadi Maki, let me turn to you. And because you have done a lot of experiments, haven't you, on different kinds of nudges, and your work is not just here in Qatar, but in the region as well.
So we started here 2 years ago, a bit more than 2 years ago, in the Supreme Committee for Delivery and Legacy, which is the organization overseeing preparation for the World Cup. So it was an initiative of the Secretary General, Hassan Thawadi, who believed that a lot of the issues that we have in preparing for the World Cup have behavioral roots, and addressing them using only the traditional methods will not work. So you need behavioral intervention. So we try to focus on 4 areas. One is sports and healthy lifestyle. The second one is entrepreneurship. Third one is workers' welfare. And the fourth one is environmental sustainability. And we've started piloting and trialing a lot of small experiments in the first 2 years, and it was amazing what we found. A lot of tiny little changes in architectures, as we call it, the changes in which the decisions are taken can have an impact.
Give me an example of one in the first category, the sport and healthy lifestyle.
Right, so one of that is about healthy eating. So if you look at the journey, it starts with buying and shopping. So it turned out that framing the way certain kind of decisions are taken, so moving some fruits and vegetables nearer the cashier as people are waiting, ends up having more people buy those.
Of course, it's normally where the sweets are.
But we kept the sweets. So the interesting thing, the nudge is supposed to be choice preserving and supposed to keep other things, just to test basically.
Okay, so what did you put then nearer
So we put 2 fruits and 2 vegetables, nicely wrapped, just next to the candies. And it increased the uptake of these fruits and vegetables. Although, I mean, one could say people are rational. If they want fruits and vegetables, they know where the corner of the fruits, so people would do it. But we are not infinitely rational. We have our bounded rationality, and therefore, a bit of a nudge in the right direction can help us. We've been testing and trialing in cafeterias, just changing the order of display of certain fruits and vegetables has an impact.
And didn't you also try and encourage people to use the stairs rather than the lift?
We did one with some researchers from Harvard Business School in the city center, where we tried to make the stairs more attractive. And that was very interesting. So we tested pre and post. We created some illustrations of high rises from Qatar, from Arab region, from the world, and we just watch to see if people would use that over the escalators. And we had variable degrees of success, but that's fine because we learn from failures as much as we learn from success. And this is a big lesson learned for all of us here in behavioral science and experimentation.
Minister, would you consider bringing in Armenia the kinds of things that Fadi is describing they're experimenting with here in Qatar?
We can try to do so together with the researchers, of course, yes.
Do you think those kinds of nudges are needed in a country like yours?
I can say that this kind of nudges are needed regardless of the country, so we can try and see what works in any country. But I know that there are a lot of similarities everywhere in the world, especially in healthcare.
Yeah, and Greg, from what you were saying, the way that the evidence is presented, I mean, the detail clearly helped in the experiments you did, but also the added information that helped, would you say that helped nudge people towards better decisions?
Yes, but it's important to do what Dr. Mackey outlined, and I'm glad you didn't talk about putting fruit on the stairs. Because what you need to do is to retain the choice. And frequently what people are given is information in isolation of comparison. And by giving them the choice, we learned this way back in 1982 in John Yates' work on hospital beds. When you compare your performance against other people's performance, it makes you think differently about your performance. So you've got to present that information, but in a way which retains the integrity of the choice.
Okay, let me turn to all of you. Could you raise your hand if you've got a question, and then we will get the microphones around the room. Let's turn, sorry, someone raising their hand there? Okay, can we get that microphone number 1 to Carlos Payo, who's sitting over there in the corner. I saw Carlos's work in the Innovation Hub, and I think it's worth illustrating because it shows, we've been talking about biases amongst medical professionals, but what Carlos has come up against, and I'll let you explain what you do, but what you've come up against is the sort of barrier that prevents a great invention getting funding in the first place. So Carlos is from Brazil.
Okay, at Brazil we have a very typical situation because there is a great mistrust between the private sector and the public sector. Investors simply don't trust on political class and also on the government. And we researchers, we work in the public sector. So it's very difficult for us to find investors to our innovations. This is our main problem. This is the main barrier to make innovation at Brazil.
And I should explain that your particular innovation is where you have used the skin of the tilapia fish, and you are trying to prove that it can be used for the skin, for skin grafts.
Yes, we developed the tilapia skin as a bandage for burn treatment, and we are still trying to find an investor.
Okay. Well, let me... Still trying to find an investor, okay? That's not even a hint. That's But, there may be someone here. But, Greg, it's interesting because, your work is assuming, of course, and there are many good inventions which are already out there, and your work this time has focused it on the barriers. But this is kind of one step before that, even.
Well, yes. I mean, we're very excited about this particular phase of our work because it's providing very practical and tangible steps that leaders can take. Maureen outlined some of those. When you're looking at at that high height from the helicopter, it's very difficult to decide how you can begin to make things more important and more prevalent. But when you can do things like put apples next to the candies, or you can begin showing people comparative cases of field, you're beginning to do things on the ground that directly have an impact on people beginning to do things in new ways and delivering better outcomes.
Maureen?
I was going to add to your point, Greg, that one of the most exciting innovations that I've seen spread was something we found in Jönköping, Sweden, which is where patients with, who are on dialysis have developed, with some assistance from the hospital, a patient dialysis clinic. I know patients do their own dialysis, but in this place, they let themselves in. They make their own appointments, they do their procedures, they clean up everything. And the percentage of patients is almost 70% doing their own dialysis with better clinical outcomes, fewer complications, and lower costs. But when we tried to spread this, we found that everybody said, oh, that population is different. A nephrologist from Waco, Texas, with an entirely Hispanic population, we flew the patient and the nurse to Waco, Texas. They taught the nephrologist how to set up the clinic. The nephrologist now has the same outcomes with his population, and he called me a few months ago and told me that he has 3 patients who are completely blind who are doing their own hemodialysis. So it's that seeing that I think really gave them the nudge that they needed to take it up.
Okay. Fadi?
Just want to mention one great innovation that was done a couple of years ago here in Qatar. And just as we know, the screening and constant monitoring of health is very important to detect diseases like non-communicable diseases. So diabetes is one of those. And what they've done is during Ramadan, when people are fasting, on the Friday prayer, as people are leaving, they tested for diabetes. And what was interesting, fascinating, is that 1/3 almost did not know that they had type 1 or type 2 diabetes.
Wow.
And this is one of the most celebrated examples of innovation because it's so easy. People will not go and test. Not everybody would, but if the test comes to them, then they would. So inspired by this, we tried to take it to the next level, and we just finished 3 days ago supporting Beirut Marathon with Nudge Lebanon, where we basically took the opportunity as people, families, runners were preparing 3 days before to go pick up their badges. We tested them for some of the cardiovascular diseases, in particular hypertension. So not only 25% tested positive, but around 76% of those were unaware of their conditions. So something like this is definitely...
So it's looking for the opportunities.
Looking for the opportunities,
okay.
Basically. And this is what we're trying to do, I think, in the World Cup, where so much could be done on the back of large sports event and could be replicated all over.
Okay. I want to turn back to the floor. So can we go to 8, 5, 1, and then 2, and then we'll come to you next time. So, yes.
Okay, thank you very much for this very interesting debate. I would like to point out one thing. I mean, we are talking about innovation is mostly referring to, in general terms, I mean, not exclusively, but to treatments, therapies, surgeries, and so forth. And I think we need a lot of innovation in public health policies also. And we need also a better way to evaluate the effectiveness of public health policies when they are applied at a population level and not in an experimental setting. So I would like to ask you, I mean, what needs to be done to encourage this type of innovation to take place?
Thank you. Question over here.
Hello, good afternoon. My name is Ricardo Leite. I'm a member of parliament in Portugal and also the head of public health at the Católica University in Lisbon. And nudging is argued in the report to be used also for better policy making, which I would agree that is necessary. But one can argue also that lobbyists, for example, could try to nudge policy makers and even administrators in a health system in an opposite way from evidence, more into their own vested interests.
Yeah.
So to mitigate those risks, what would the esteemed colleagues think could be done? And on the other hand, wouldn't you agree that there is a need to constantly assess the outcomes of all of these measurements, because we're pushing people in a certain direction based on current evidence, but we need to make sure that we're always on track so that we can keep the system nimble and continue to adapt. So these are the 2 questions I'd like to leave.
Thank you very much. And I'm going to take, yes, over here.
Hello, my name is Hutan Ashrafian. I'm from Imperial College London. The group demonstrated very elegantly the role of cognitive biases in day-to-day healthcare. The question is that they've presented some nudges which would be very powerful in potentially changing practice. To what extent should we also be teaching the healthcare providers about those cognitive biases? And in terms of the training and the education, what is the role of technology, particularly online platforms, that can be used here, or are they all person to person? You talked about the day, Maureen, about one day. Can we do that online and automate it?
Okay, thank you. And then last in this section, this one there.
I'm Peter Jones, a professor at OCAD University in Toronto. One of the major sites for innovation is the hospital itself. Architects have been promoting the change to the decentralization of hospitals and the change of the built form for healthcare for a number of years. 10 years ago, when I was hearing from futurists that the hospitals would be going away in 10 years and would be replaced, and they aren't. In fact, so what are the contexts for the change to hospitals and services? What are the barriers to the uptake of innovation, to changing the way we need to change the built form for providing clinical services?
Okay, thank you. So why don't we start with those two last ones before we come back to the earlier points that were made about the need for innovation in public health policy, and also the point about decision-making based on lobbying rather than evidence. Maureen, do you want to pick up on one of those, the third or fourth point there?
Sure,
first?
and actually my thought goes across from public health to your question about the physical plant, because I do think that the biggest nudge we could make right now is to move outside into the community and see other partners as healthcare providers. In Dallas, Texas, as an example, the African American population was very unwilling to go to their primary care physicians because of a trust issue, and because they tended to be diagnosed with diabetes and chronic lung disease and obesity at a much higher level, and they didn't like the fact that they were diagnosed as being sick. So they went out and they trained the barbers to take blood pressures. And the barbers, who have incredible trust with their customers, cut their patients' hair, and then at the end of the haircut, they say, "Can I take your blood pressure?" And everybody says, "Sure," and they take the blood pressure. They write it on a little card, and if the patient gets somebody from the physician's practice to sign the card, their next haircut is free. So we've created an asset loop in the community that focuses on trust, but it does go beyond the walls, and I think eventually, I was saying today that my favorite article recently was, does every hospital admission need a root cause analysis? Because I do think when we start to think in that way, it'll push us out the doors and give us a whole lot more assets in the community.
Greg.
I think that as an architect, I think that the design of hospitals is not something that you can affect through nudge, but I do think you can affect it through simulation and experimentation to discover new ways of providing care within the built environment. I remember the Michigan Coronary Care Project back in 1977, which began taking a look at the then new development of cardiac care and built actual simulation units in which, using resuscianes, but real healthcare professionals, began to measure the effects of different architectural designs. I think we can do that. It makes it really important that one of the recommendations that we make in this report and in all of our other reports is followed up, and that is to make sufficient time for learning.
Yeah.
That's something we're not investing in. We're not taking time to experiment, to simulate, to learn. We're not taking time to build the kind of nudges we need to do. And unless we do that, unless we make that investment, which is often politically unpalatable because it means that you're spending money before you're getting return.
Yeah. Well, you
we're
could
not
see
going
it
to
as
be able to do it.
unproductive time, or you can't track it so easily,
right.
but we shouldn't see it that
That's
way,
right.
I think you're saying.
That's right.
Fadi.
I just want to pick up on two questions. One on the misuse, potential misuse of nudges. Of course, that is something that is worrisome. That's why we call for more transparency for when adopting behavioral intervention, pre-trial registration, transparency, even celebrating failures. making it more difficult for people to retract once they've started an intervention. So there are so many good practices that we're trying to promote, not only among government, but also in academia and in NGOs, and nowadays more with private sector. And we're calling for more codes of conduct for this kind of work. And ethical reviews is becoming more and more often. Not only, of course, universities have IRBs, so they do that, but not everybody has that. So it's important for governments, NGOs, and private sector to start having some kind of ethical review. On the training, I think this is one of the most important things that I think you speak about in the report, because we've been doing for the last 2.5 years a lot of capacity building training in behavioral science, telling people, operational champions in areas of health, education, environment, bringing to them the basic knowledge about behavioral economics, about cognitive biases, about nudges, about how to simply design experiments. And we've seen beautiful things happen, even at the end of a day or two, when exposing those people in their own areas to examples, benchmarks, successes, failures. They start bringing in the best and try to apply it in their own areas. So this is extremely important, because that will open their eyes. It would tell them what works, what does not work. But more importantly, it brings in the culture of experimentation, because what we want to promote is the fact that what works is evidence-based. It's not what we think works, is what has been tested to work. Yeah. That's why some of it is no-brainer. You could try to replicate it, but a lot of it, context matter. One more reason why you should experiment and experiment.
Yeah. Minister, I wonder what you think of either the point made by the Portuguese MP or the point made before that about the need for innovation in health policy, that it shouldn't just be about the product or the way of working, but the policies as a whole as well.
Yes, sure. We have to listen more to the researchers and take time for learning, as already told, and don't make quicker and quick decisions that can be wrong in a time manner. We may take time, yes, sure. And about the lobbyists pushing us to the wrong direction, I think we should always remember that can be pushed from bottom up, and be prepared for I cannot say the fight back, but at least to hold on our positions, and based on the recommendations that we get from the research community.
Yeah. Okay. I'm going to turn to question 4, followed by question 3. Let's take those two and then come back to the panel. Go ahead.
Good afternoon, everybody. It's the second time I've had a chance to ask a question in this hall. My name is Robert Johnston. I'm representing the International Foundation for Integrated Care. Just to say that as a wheelchair user, it's quite difficult to get the chair's attention, but thank you very much for finally picking up on that. I'm feeling very much that we're talking about innovation and diffusion, but you're forgetting the most important component in healthcare, which is the number of patients you have out there. And they are not just a problem, they are a resource. And the sooner we start including patients individually in planning their own healthcare and initiate a shared decision-making process between the physician and the individual patient, and then moving on and using the collective experience from patient organizations, which exist both locally, nationally, and now internationally, and bring those into the whole process. Everybody knows that people learn best from their peers. So those of us who are already exhibiting good, positive healthcare decision-making can be used to help other people learn to do that. And that when you also start to treat patients as an integral part of a democratic process, then politically, economically, in every way, you will get a better outcome. So please, I'd like your comments on that.
Thank you very much. Thank you. And let's take the second one we identified down here.
So my name is Zied Mahirsi. I'm with the Tunisian Center for Public Health. My question is regarding vaccines in general, as as a tool that we know prevents a disease. Australia, for instance, started a vaccination campaign 15 years ago on the HPV and announced that they will be eliminating cervical cancer in 2028, meaning like just a decade from now, eliminating a cancer. We know how much in the region we're sensitive to cancers, but our region, for instance, seemed to be reluctant to vaccines, and is this a setback in diffusion of innovation, while we knew in the last decades we wanted it? Like if we think about Qatar, they, for instance, are at the same threshold as Australia, on track on elimination, but yet something as simple as vaccine is not yet available
so are
here
you
in the
wondering
region. So
how that can be overcome, that sort of reluctance?
and how we also defend our region from like setbacks in diffusion.
Yeah.
So I feel like innovation is adopted in certain eras, and then sometimes we go backwards, and how we can avoid that. Thank you.
Okay. Maureen, I wonder if I could come to you first on this point about patients, because I think you have done some work that recommended changes in how doctors talk to patients and how they set goals with them.
I couldn't agree more, and I'm delighted that you brought this up. It really was one patient who started this whole patient self-dialysis unit, which is now spreading, not quickly enough, but spreading reliably around the world for different patient populations. But it was a patient and his nurse who began that. And what that says is that the idea of co-production of health and care is really, I think, the pivotal change for us to take on in this next decade. What I suggested after reading an article by Susan Edgman-Levitin and Michael Barry a few years ago was, I said, you can't only ask your patient what's the matter, you have to ask what matters to you. And some nurses picked that up. And what matters to you is now spread globally. There are about 50 countries. Every year, there are about 20 million tweets on one particular day when staff have said, what matters to you? And that's changed both the care design and improved the health and the outcomes of the patients.
Greg, did you want to add something?
Yes, I think that with regard to the patients, I think that involving patients in the co-production of innovations is really important. However, and I'd also like to say that patience is too late. We really need to engage people before they're ill in considering the kinds of innovations and the kinds of public health policy innovations that need to be taken into place. Stephen Dorrell made the point the other day that we're citizens first and patients second. And what we really want to do through innovations in public health policy is reduce the number of patients. That said, once people are patients, it's really essential that we involve them in the co-productive design of new ways of working.
Okay, Fadi.
Two quick comments. One, co-creation is the word we use when we're designing behavioral intervention, because this is a key success factor. It's one thing to think that this is going to work and then bring it and try to test it. Another thing to try to bring as much feedback as possible from those stakeholders. The other point, it reminds me of a session we had yesterday with Dean Linda Fried from Columbia University. She's been speaking about the life course approach. And this is very much to what you've been saying, Greg, that is, you need to start much earlier in life. And if I can think of it as 3 stages, the healthy lifestyle and prevention, essentially addressing many of the risk factors like eating healthy, practicing, and so on. Second one is the detection, early detection of the disease. But once this is done, then there is a lot that could be done for medical adherence. And it's like a continuous process where behavioral insights could be used to support.
Okay. I feel I would be remiss if I didn't explore this point about nurses being more willing than doctors to embrace innovation. Maureen, am I right in thinking that you are a trained nurse?
Yes, I am.
Right. What do you make of that finding?
I think it's in my experience, no data, it feels right. And the reason I think is because we tend to spend more time with patients. We tend to spend more time with families, and we get to see the whole spectrum of the impact of disease. We also get to spend time before someone gets sick, to Greg's point, and to work with a family and to try and build preventive measures in there. So I think there's a normal closeness between a nurse and a patient and family, a community, that allows us to see potential innovations in a new way.
Yeah.
We're a lot less focused on a procedure or an organ and a lot more focused on the total family.
Yeah, but of course, Greg, there could be very good reasons, and there probably are very good reasons, that a doctor wants to continue with a tried and tested method with which they feel comfortable.
That's true. I would add to Maureen's points, however, and I think this relates in part to Hutan's question about training. In my experience, nurses are inclined or liable to work with a much broader range of professionals than doctors are. Yeah. And doctors are frequently working on his or her own and have to rely upon their own instincts and judgments and thus on their own cognitive biases. So that may be an answer. Can I just make a point about the vaccine?
Yeah. Yes.
Actually, one of our case studies in the 2015 report was about the rapid diffusion of cervical disease vaccines in Argentina. So we can diffuse vaccines rapidly. Argentina has proved it. I suggest the questioner might take a look at that report.
Okay, thank you very much. In just a few seconds, I'd like to end by asking you all for the question that's been asked right across these 2 days, which is your one wish for healthcare. Minister, what would your one wish for healthcare in Armenia be?
One wish. I can wish that all my citizens are healthy so that I don't have any job to do.
Fadi?
I think if we want to create behavioral change, let's try to make it as easy as possible and experiment, because context matter, and what works is what has been tested to work.
Maureen?
I would say that as leaders, we would take on the challenge of diffusion, and that's going to require structure and maybe even a new job. I keep thinking we need a head of spread.
A head of spread, okay, and more exnovation, which is a word I've learned from you, doing away with the things that don't work. Greg, your one wish?
Fewer patients.
Yeah, well, that's true. That would be good for everyone. Thank you all very much. Please join me in thanking the panel.